up another important video, another important ECG. So this is a patient. This is an ECG of an old patient who came to the ED with a history of syncope. One episode of syncope was there, and there was many previous history of pre-syncope in last 3 to 6 months. So if we see the ECG, we should at the very first we should check all the parameters of the paper speed and the voltage. They are all normal. But whenever we see the ECG, we can see that the RR interval is not very regular here. We can see in some portions the RR interval is very normal like this, and in some portion the RR interval is very prolonged. So we can see that there is some bradycardia as well as some tachycardia. So bradytachy pattern of ECG we can see. And if we notice that there is no POF. So whenever there is no POF, we call it a junctional rhythm. Okay. And junctional rhythm, we know that it might be junctional tachycardia, it might be junctional bradycardia. So junctional rhythm is that the rhythm is being produced from the AV junction, not from the sinus node. So that also in a different way, specifically when there is junctional bradycardia, in a different way that also denotes the sinus arrest. So it might be junctional type or junctional brady. So in case of junctional brady, there will be no POA, but there will be normal QRST, no POA, normal QRST like this. In junctional brady, the RR interval will be prolonged. And for in the most of the times in the junctional brady, the heart rate is less than 50 or less than 40. But here we can see that there is both, uh, sorry, we can see that there is both tachy as well as brady. So we call this a brady syndrome. We call it as tachycardia syndrome. The first thing we should remember that this might be due to some drugs and another condition that is called 6NS disease or 6NS syndrome. What type of drugs we should be ruling out? We should always rule out drugs like beta blockers, calcium channel blocker, and some anti-arrhythmic drugs like the drugs we use in atrial flutter or atrial fibrillation, like amiodarone, amiodarone and cordarone. Amidala and Codarin very commonly causes this type of sinus bradycardia or this type of presentation. So if you are giving a patient at Codarin or Amidala for atrial fibrillation, but if you don't monitor the patient, uh, you have given the bolus dose. After that, you've given a maintenance dose at the evening time. And if you have monitored the patient, have that even monitored. In the morning time, you might say that the patient has gone to bradycardia. So we should be very cautious while giving the maintenance infusion of the amiodarone or now, another entity is the 6NF syndrome. 6NF syndrome might present in different ways. 6NF syndrome is that the sinus node is problematic. The sinus node is functioning usually. So it might present with tachy, it might present with brady, as well as tachycardia type of people. There are different type of presentation like one is that we are seeing here, tachycardia syndrome. There might be sinus body, extensive sinus body. The heart rate would be less than 40 beats per minute. There might be chronotropic incompetence. Tachycardia, we have seen sinus body, we know how to see. Chronotropic incompetence, like suppose patient was having the atrial flutter type of vision. Okay, then suddenly she will have a long sinus pod. So this atrial flutter, this is atrial flutter. So and then followed by the there is a long sinus pole. So this is called chronotropic incompetence. Okay. So but we see and there is no POL in this disease. So this is a tachycardia with sinus arrest. This is a definitive indication for class 1 indication for pacemaker implantation. Most common disturbed pattern tachycardia 6 sinus syndrome is most commonly seen in the older people, more than 65, more than 70 years. Definitive indication of pacemaker implantation. Thank you.